I'd like to bring Sarah into this conversation, and it's on treatments, or it's on the CLL kind of landscape, that if you have a subset of patients that we know that their CLL will never progress to a level that they'll need treatment, is there anything happening maybe in research to kind of pinpoint who them patients are? Because wouldn't it be wonderful to know that you have this low-level CLL and it's never going to cause me a problem?
Do you mean, Michael, intervening during that active surveillance period? Is that
during the active surveillance, the patients that may be on the monoclonal B-cell lymphocytosis, that's a precursor to CLL, and maybe have gone on a little bit, that their B-cell number is up, but it never seems to, it goes up and comes down, and they go on for years. But if you're able to tell them in the early days, and I know it's a tricky question, I know it's all in research, and every time I go to the conferences, I'm always kind of interested, is there going to be some test to say, well, actually, hang on, you're the patient that will probably never need treatment?
I suppose that is quite a difficult question to answer. I think we reflected this morning that about a third of patients, when they're diagnosed, may never need treatment in their lifetime. In terms of that early precursor monoclonal B-cell lymphocytosis then progressing to CLL. I'm unaware of anything in that space just at the minute, but certainly sometimes even patients with early stage A disease, there are groups of those where through some prognostic scores you might deem them to be higher risk of progression, and certainly their genetic makeup and other features about their disease may help try and predict that. We presented this morning the CLL-12 trial, which looked at a group of patients who were early stage but thought to be higher risk of progression, and earlier intervention with ibrutinib didn't seem to impact their overall survival. So certainly there were no changes to our current practice. And at the minute there is another trial called EVOLVE, looking at a different combination of targeted therapies, obinutuzumab and venetoclax, but that trial hasn't read out yet. So it is an area of great clinical interest, and there are ongoing trials, but I think at present we certainly don't have the evidence base to suggest any earlier intervention than what we currently do in our clinical practice.
I remember in the early days we were looking for a clinical trial in the south of Ireland, and there was only one trial with 9 places on it for over 65s, relapsed refractory, and then you have a patient that's 39. And hence we had to travel to the UK. But at that time, the UK was in the European Union. It was difficult, but it was a bit easier than now. The doors all seem to be closed. And I know we keep all hearing about this all-island access to healthcare and researchers. And I think there's even a memorandum of understanding within Cancer Trials Ireland that you can look this up online, but they've signed a memorandum of understanding with Northern Ireland, with the US. But I don't see it for patients. I see it for researchers, and I'm wondering, do you see a time that patients maybe in the south can come up north to clinical trials? Because what I'll just add is that we will have a clinical trial in the south of Ireland, CLL-18, Jan, am I right? CLL-17? CLL-17, so it's a German study, and I'm sure that the patients in Northern Ireland, if they know about that trial and they know the arms of the trial, they'd be interested in accessing it. So, Ben, I'll go Ben first.
Yeah, I think CLL-17 is probably just about closed now. CLL-18 will open up shortly, and that's going to answer some interesting questions about an MRD-driven approach combining BTK inhibitors with BCL2 directed drugs, as well as looking at I think there's a Veno arm as well. So it's kind of fixed duration, but adding drugs in to look for an MRD output as well. I just want to turn this around, because I think we can get fixated on sort of a magic bullet thinking with all of this. And one of the points I wanted to make with the last question was, well, you can factor in some of those genetic tests, but at the end of the day, it's not all about the genetics. There are other and potentially much more important things to think about. First of all, as we've established, not everyone needs treatment, and that's a big area, because it opens up a can of worms of all sorts of uncertainties, and psychologically that's a difficult thing, and I'm sure we're going to come on to discussions about what active monitoring is. But that's a massive part of what we do, and that's much bigger in many ways than that pivotal moment where you have to start thinking about treatment. And the temptation is to think, well, what's the very best treatment that you can have, and what's the fantasy combination that we could have in terms of deciding where we go with the therapies. But we also need to consider what is important in people's lives, what their priorities are, what they want to get out of treatment, how fit we are to begin with. So what we call comorbidities, which is a delightful term to add up all the little things that are wrong with us, from our hip replacements to our atrial fibrillations to our COPDs and all the rest of it. So there are many, many more factors. So sorry, Michael, I've deviated on there. What was your question?
I can't remember, but it was all good. Do you know what I might do now? And sorry if I took over. If we have a question, I see one hand up already, so I'll bring the mic.
Yeah, you're about to expand on the BTK. I hope I'm using the right terminology, like a tablet form versus a fixed term. I'd like to hear a little bit more about that, please.
So I think for people approaching treatment, Ken, I hope we have a discussion about what that means, what to look out for, the language that we use around it. But at some point, there may be, for many people, a time when we need to consider treatment. So a BTK inhibitor, there are several on the market at the moment. They all work extremely well. Ibrutinib was the very first one that came along. In general, now we have a choice between acalabrutinib and zanubrutinib. They work very well, very similar mechanism. They bind to this thing called Bruton's tyrosine kinase, which is a protein just underneath the cell surface that links to a receptor on the cell surface, and it sends a signal down into the nucleus of the cell. That means that the cell is switched on, it has a survival, it can thrive, it can live. And in many ways, CLL cells are absolutely dependent on this background signal that they get, like food and drink, to the cell. It's nourishment to the cell, chemical nourishment through the B-cell receptor. And by blocking that with the Bruton's tyrosine kinase inhibitor, that's a tablet treatment that you take continuously, it's like controlling some other condition, like controlling high blood pressure, like controlling many other long-term chronic conditions. The cells are essentially switched off. They disaggregate, they fall out of lymph glands, and they begin to appear in the blood, which is why we sometimes, in the early days, started to panic because we could see the blood count going up and then back down again over a period of weeks or months. And the cells are stunned, and they just gradually die off. And it's a great way of controlling the disease over a long period of time. But it doesn't come free, okay? It's not without its problems. And there are numerous side effects and risks of a BTK inhibitor. So, am I okay just keeping talking? Is that all right? Just throw in it. I'm aware that my very experienced colleagues here can...
I'm going for a cup of tea anyway.
can interrupt at any moment if I go off piece too far. But essentially, these things don't come for nothing. So when it comes to making a decision about is treatment going to be the right thing for me, how is my CLL? How is it affecting me? What kind of symptoms am I getting with it? What's my bone marrow function like? Am I struggling with other of these comorbidities? What impact would treatment have? So treatment might turn the clock back, reduce blood counts and make it look better on paper, but is it actually going to make me feel better? Am I going to live longer and be a better person and get things done? Well, there has to be a bit of a balancing act between the benefit and the risk. So if CLL is getting in the way, then starting to make tracks into treatment and working out what might be the best option then becomes much more realistic, because you stand a good chance of being better if the CLL is built up. If the CLL has not built up and you're fine with it, I don't mean fine in in the way that you would want to be, infections, fatigue, life being different. Okay. Those things are in the background, churning away, but things that we as clinicians often use to make decisions around, for example, anemia, low blood counts, big lymph glands, losing weight, becoming extremely just unwell in ways that you perhaps weren't unwell. Then the trade-off is many of those things are going to be better. So you can balance the risk of infection, you can balance the risk of hypertension, you can balance the risk of atrial fibrillation or bruising, bleeding problems, gastrointestinal upset, skin rashes, various things that might occur with a BTK inhibitor. So everything just has to be sort of in balance. It's a bit like if your ship is sinking, you want to be able to step up into the life raft. Okay? You don't want to jump into the life raft if the vessel is still seaworthy. So if your body is still seaworthy, don't go leaping into a life raft.
And just to complete the fixed term, just the fixed term then versus that.
Yeah.
Does it come down to your personal health and etc.?
So, it's a really good question because, what does it mean to have a fixed-term treatment? We think of those as being based on drugs like venetoclax. So this, again, is a small molecule targeted treatment, gets into the cell, and it switches on this cell death pathway a little bit further down from the P53. So it forgets P53, waves that one goodbye, gets to the heart of the matter, pulls a lever, and the cell dies off. It's called apoptosis. And it kills cells directly. It's very, very exquisitely effective. The cells are exquisitely sensitive to drugs like venetoclax. So what it does, it gets into the cells, kills them off really quickly. And the beauty of it is you don't need, if you combine it with combinations like an antibody, such as obinutuzumab, licensing changes depending where you are, but you can use it in combination with ibrutinib as well in certain geographic places. That's not available generally within the Republic. It is available in the United Kingdom. So that fixed duration therapy is usually over a period of about 15 months. So the advantage is 15 months, that flies by. That's a relatively short period of time. And then you get to the end of it and you can then live your life. And most people will have a very useful remission with that. For many people, it will do. In the context of P53 deletion, it probably doesn't, but that's an average. But it probably doesn't for if you have a P53 problem. But it'll still work well in a shorter term. So if there's no other choice, then that might be right. And people can have it at all sorts of levels of fitness. We have to look out for various things like kidney function, for example. So there are circumstances where you need to think very carefully about how you use it and just treading warily with it. But most people can manage it very well. So it can come down to a personal choice about what you prefer, what you think might be suitable for you, what kind of other health problems you might have. So there's more to it than just the genetics of it. And I'm sure there's a perspective, Sarah, as well. So what are your thoughts on it?
Well, I agree with everything that you've said there. I think when there is a choice, it's understanding your lifestyle, and as Ben said, your other medical conditions, and then exploring those options, hopefully taking some time to describe what those two pathways would look like for you as an individual, give you some time to think about it. As Ben has said, certainly those patients who have a TP53 disruption or deletion, I would agree. I would go with continuous BTKI as your first line of therapy because there's more of an evidence base to support that. But beyond that, I think there are good choices in the frontline setting, and I think the majority of patients will do really well no matter which option you choose. So some of it may come down to personal preference and lifestyle. For some people, for example, recently I had a chap start on a fixed duration because he was on warfarin for a mechanical heart valve, and I wished to therefore avoid a BTKI, and it seemed like a better fit for him. So there will be things like that, like other medication you're on, other medical conditions. And also, as it was sort of reflected a little bit this morning, only touched on it briefly, whichever you have in the front line, should the disease become active again down the line, you can still then sequence another class of drug at that point. So I think the take home from today, as I said this morning, we have really good options in 2025, and even in the second and third line, we still have very good options, and the area is changing and evolving at such a pace. So it really does come down to a shared decision-making process where we take our time with you, explore your needs, explore your CLL, and then try and make that decision together. And no doubt there will be problems sometimes. These drugs, while they are much better tolerated than things we used in the past, they do have their own side effects. But that's what your clinical team should be there to help and support you through. There'll be wee blips along the way, but we have to do our best to navigate our way around those and keep you as well as possible while on the treatment.
And we have another question here as well.
I just want to ask, the question is, if you're on the long-term BKT, and all these new ones have come on where you'd have dead end, do you think changing is a good idea, ever?
Do you mean changing the BTK inhibitor?
Yeah.
I think in general, for people who don't develop mutations or resistance to a BTK inhibitor.
But if they're managed through more drugs?
Yeah.
If the side effects are managed through more medication?
Okay, so I think there are probably two reasons to discontinue a BTK inhibitor. One would be if it's not working, and the other one, I think, which you're getting closer to, is what if there are problems? Can you change it around? Can you swap it for something else? And I was involved in a study using acalabrutinib for people who had side effects with ibrutinib. And sure enough, if in the absence of disease progression, for those people who were experiencing problems with one of the BTK inhibitors, you can then switch into a different one. There are pathways to do that. And that may help the side effects. That may help the side effects. It doesn't always. Some drugs may be more associated with headaches or maybe more associated with hypertension or something. What you can't do is swap into a different established BTK inhibitor in the context of disease progression, because that would imply perhaps that there's probably some kind of mutation in the BTK itself, which stops the drug from binding in the first place, so it doesn't work anymore. But there's lots of subtleties around that.
Okay.
So does that help answer the question?
I'm just wondering why, with the side effects, it wouldn't be changed. It would, is that normally what you go with?
I think a lot of the time we simply have to manage what we've got in front of us. So if somebody developed hypertension, we have to find a way of managing the high blood pressure. If somebody develops atrial fibrillation, I don't throw my hands up in horror and say, oh my God, you've got to stop your zanubrutinib, your acalabrutinib, whatever it might be. I'd say, okay, well, listen, we've got to manage your AF. Here's, what you need is probably to control the rate. Let's think about a beta blocker, okay? Because atrial fibrillation is associated with a risk of stroke, then an anticoagulant is probably the right thing to do for the vast majority of people. So then you're stuck with a situation of multiple drugs, paying Peter, robbing Paul, and all the rest of it. And you can end up building up like that. What do you think?
I couldn't agree more. Yeah, absolutely. It is about trying to manage those side effects as best we can. But I would agree the main reason to stop a BTKI would be if the drug is no longer effective or if the side effects become unacceptable for some other reason. But most of the side effects we do have experience now in the management of, and we would try to mitigate those in whichever way we can.
So Laura, I bring you kind of back into this conversation. When I first started in advocacy, I always thought that the patients at these events always wanted the scientific stuff. So you probably know that I'm kind of taking all these scientific questions, and so I brought the psychological impact. But bringing that into it, what do you see the most need for patients that come and see you, or is it like CLL? Is it a different disease for every patient? Is everything different, or do you see a commonality?
I suppose a commonality is that most of my phone calls when I was a nurse specialist would have been patients, as I say, newly diagnosed but not needing treatment. They active monitoring, watch and wait. I will see you in 6 months. So that is a huge proportion of my calls, and managing the psychological impact of that, and also fatigue. So fatigue was, I suppose, another like 80% of my phone calls is managing. And again, you don't have a magic pill. You don't have a magic piece of advice. What works for one person doesn't work for another. And it is a very, very difficult side effect. And then you put people on treatment whenever they need treatment, and then you get fatigue because of the treatment. So it's kind of like this mixture of cycle. And it would be lovely just to have something to say, well, this will make you feel better. And it doesn't. So it's quite difficult to manage the psychological impact and the fatigue. Both of those is probably the hardest.
Brian, if I bring you back into this, that we know that COVID had a big impact on our patient community, and from an advocacy point of view, it became difficult for us to stay connected with webinars and all that. So how did you find, or how is the landscape kind of different now because of COVID, and how you deal with patients through a patient advocacy?
Yeah, very good question. COVID was a real problem for everybody. Of course it was. We, as a charity, went into webinars because people still need help, people still need information, but we couldn't hold events like this at all. And it made everyone feel, it made me feel, everyone feel totally isolated. So we expanded, we started webinars. We'd never heard of them before, and we started them, and we carry on with them now. If I may, Michael, can I ask a question of someone on the panel? You get someone, how do you answer the psychological? How do you tackle that? Because I'd be very interested to know what your response is. I know it may be different for each individual person, but there must be a generality of how you tackle it.
So usually we start off with questions generally, what have you been told? What have you understood about what we have told you? And what are the bits you find difficult? And by putting it to what is important to you, that's usually what comes back is, well, managing my fatigue or managing psychological aspect. I don't know how to tell. I don't know how to explain this to. And so we usually build on it from that point of view. And then from that, we then ask, well, what support systems do you have in place? What's available to you? And then where do we need to signpost you to? So it's extremely individual. Some patients want to talk from day one about their experiences, about, their diagnosis. Some patients will come to us 2 years later, 3 years later, 4 years later, and then want to talk. So it's extremely individual. And then we're into difficulty of where we're signposting people, what's available to us. I suppose we're working within the NHS in Belfast. We don't always have very, very easy access into psychological services. There's long waiting lists. So then we signpost out to charities which also have waiting lists. So then we've built in holistic needs assessment clinics with nurses to see if we can give some level of psychological support, but it is very much signposting patients where the need is. Lots of patients find peer support extremely valuable, whether that is closed Facebook groups, us trying to buddy people up in the waiting room, or whether we send people to Lymphoma Action or CLL support to find buddies that way as well. But it's very individualised.
Yeah, that's interesting. I think one mention there was the buddy scheme. If you ever want to talk to a fellow patient and you can't come to an event like this, and not everyone can, then the buddy scheme that we operate with Leukemia Care, and also I know you operate as well, it is very, very useful. Not for everybody, but it is a useful contact, and they can put you in touch. We can put you in touch with someone either at the same sort of level that you are, maybe active monitoring, maybe awaiting treatment, maybe post-treatment. And it's amazing what a difference it makes just to talk to somebody, to know that you're not on your own. People are going through exactly the same thing that you're doing. You have a buddy scheme as well, don't you?
Yes, we have a buddy scheme which is very specific to your subtype where you are, but also obviously the charity helplines. I mean, I don't know about the other helplines, but certainly ours. in the olden days, I had lots of calls and they were for information, whereas now people are very savvy at knowing where to get their information and getting it online and getting it through booklets. So a lot of the calls we get are now for psychological support and help. So they can be longer, they can be more emotional, but that's what the service is there for. During COVID, I think all of the helplines had a massive increase in people calling for support and help because of the uncertainty and not having the information. So, helplines are in some way traditional compared to the, online, digital, hybrid services, but they definitely have a very special space for being able to give you that one-to-one contact with someone to speak to, because you don't want to always speak to family members, or you may feel that you just need to speak to somebody outside of your network, somebody independent who will just listen and will understand what you're talking about and the way you're feeling, and if you're on active monitoring or you're about to start treatment. So I definitely think helplines still have a very good special space for that as well. But yeah, we get the same kind of queries. Fatigue always comes up. Anxiety and depression as well. And what we found from our surveys were that people don't talk about those things necessarily to clinicians. They will think we talk about treatment, the medical aspect, and that these are other things that, we shouldn't bother the healthcare professional with. But actually you should. You should talk to your GP, you should talk to your healthcare professionals and to your nurses as well, because there is support out there. But you've got to also be, willing to ask for that help and to then seek out the support as well. And I think there's lots of interesting trials and different things going on in different hospitals. I think it's in the Dublin hospital where there is a specialist nurse that is dealing with psychological support, or they were trialling different kinds of psychological support mechanisms depending on the severity of how people were feeling. But yeah, I think goes back to just asking for help and knowing where to go and get it from the charities or from the healthcare teams.
And on that note, we have another question here. This is Josephine, by the way, who's one of the founding members of CLL Ireland, so I appreciate that. Appreciate that she came today.
Thank you, Michael. And this isn't a question, this is just really for the patients in the room, like myself. I was thrilled to hear the words, on average stressed, so strongly. And the way you've touched on the complexity of the disease and how things are changing. Because I'm a patient who was diagnosed 11 years ago when we were on the cusp of the move away from chemo. But I developed very quickly. I was diagnosed in May 2014, and in less than a year I needed treatment. And I knew about the mutational test, which hadn't been done for me. And I was terrified to go into chemo, and I was looking for clinical trials and couldn't get a clinical trial. And I got the result of my mutational test when I was on the second cycle of chemo. So I was unmutated, and I thought, I'm not going to get any remission. I'm destroying my bloods now. I'm going to be sick for the rest of my life. I'm going to die very soon. And catastrophizing, as patients do. And what I've learned from my experience, I'm now 9 years plus in remission, although I'm unmutated, is that no matter how good or bad the prognosis is, no matter what the genetic tests tell us, it's the on average that they're telling. And every individual is different. And even as patients and as educated patients, we can never know the detail and the complexity, because it's the disease. Even the experts don't know what's coming. And I think that we just accept that uncertainty and know that there is always hope. We have fantastic clinicians, fantastic nurse practitioners who are going to help us and support us. But I suppose the message I'm trying to say to patients in the room, from someone who was for about 4 months thinking, I'm not going to get any remission and I'm going to die very soon, and I was getting blood transfusions. My chemo stopped after 4 months. My bloods crashed. I was nearly 9 months getting blood transfusions every 2 weeks. And I thought, this is my life, whatever's left of it. And it wasn't. I've had this wonderful 9 into 10 years. And I just would say to every patient in the room, don't get hung up. If you do get genetic tests, don't get hung up on the test results, and keep that sense of hope that things will work out, because we have great support in both the patient advocacy and the clinicians that we have in this country, and in England as well. And we're very, very lucky. And that's just all I wanted to say. It's not a question.
I just have to state, is on the back of what Laura and Ropinder were going on about, is an important thing. I wasn't ringing up, you can ring up Marie Curie or whatever and all that end of things. I wasn't really into that. I've researched on the web. I'm on treatment since last September, diagnosed just around this time last year. Your mind has shifted. And one of the important things was getting work out of there. And I'm lucky enough, I'm not self-employed. My employer's good to me. But talking to the patients in the wards, I sense, and you can confirm with me here, we're very lucky with CLL and the treatments that are available, the toolbox that is there. I don't know how it is to relative, but the number of people, different types of patients that are in the wards. But what I have learned, I didn't have a good Q1 this year with infections, but I've learned a lot from the patients in those wards, and I have to thank them so much. It was basically switching your mind, giving you a good kick up the bum, right? As in changing your attitude, get work out of your mind, talk to that social worker, right? And that social worker got me onto Macmillan and stuff, fatigue awareness courses, and it's stupid wee things like get your blue badge. I don't need it every day, but an odd day it might help. And it's just switching your mind. There is help there, but talking to other people on the wards, and they might be very ill or whatever, but I see this, I think the people in themselves see it as it's their job to give back. They've been helped along the way, and they're helping people in the ward. It's up to us to help people that haven't started treatment yet or maybe worried about it. I was launched into it very quickly. Don't worry about it. The team up there to the left, 2 people to the left, are looking after me. No bother. So don't worry about it. You'll be looked after. But I just hope that helps people. And it's absolutely brilliant talking to people in the room here today. And thanks for everything. But talk to people in the wards. Everybody has their own kind of way, but your mind has to shift and get away from those negative things and latch on to the it's a very much a mental thing, Laura. And I don't know, some people are, I'm not a worrier or whatever, but you have to latch on those positive end of things. And I remember Dr. Lawless, if you don't mind me saying this, when I had to switch treatment, I know people were talking about that because of side effects. I was mentally, that's a big shake-up. And you mentioned about this is a marathon, not a sprint. And exactly right. Thank you.